our next patient is very interesting. So we all aware that for resectable stage 3 lung cancer, that surgery should be done, and we know the option of neoadjuvant and adjuvant therapy before and after. But if you look at the Pacific data, which have used concurrent chemo-radiotherapy followed by 1 year of adjuvant Durvalumab, the recent data is pretty impressive. So median survival for stage 3 lung cancer is around 4 years now, and 5-year overall survival is around 43%, which is pretty impressive. So the question is whether non-surgical treatment with concurrent chemoradiotherapy followed by adjuvant Durvalumab should replace the surgical treatment for resectable stage 3 lung cancer. And for the motion, to speak about for the motion, we've got Dr. Dodul Mondal. Dr. Dodul Mondal is a senior radiation oncologist currently holding the post of Associate Director of Max Super Specialty Hospital, Saket, New Delhi. So over to Dr. Mondal.
Thank you, Dr. Animesh. Good evening, everyone. And thank you, the organizer, for giving this excellent opportunity. So when I initially looked at the topic, I thought it's very simple. But then when I looked into more detail, I saw that it's actually, I have to speak for the motion. And the topic is about resectable stage 3 non-small cell lung cancer. But the current data regarding Durvalumab, we all know that the study was actually done for unresectable lung cancer, and we will gradually see what it is. So let us see what actually this stage 3 means. And so in short, N2 disease with early T stage, or N3 disease with early T stage, N2 disease with T3, T4, N3 and T3, T4, T3, T4, N0 and N1. And essentially, when you talk about resectable non-small cell lung cancer, probably we are going to speak about specifically this stage 3A, N2 disease. Now, this is a very heterogeneous group, and there are wide variation in terms of in the T stage by virtue of different organ involvements, and one can go through the staging to see how it is widely variable when we talk about stage 3 lung cancer. So now resectable stage 3 lung cancer and whether surgery is an option, it's really a big question whether surgery should at all be considered when there is really lack of convincing data for surgery. Now, most of the trials or most of the studies where surgery have been utilized, it's actually combination of chemotherapy, surgery, and or radiation. That means someone is actually utilizing multiple combinations of treatments, making the toxicities more, giving more cost to the treatment. So for this stage, surgery essentially remains a controversial area, and it's actually part of a combined modality treatment. And you will see essentially that even in NCCN guideline for stage 3 lung cancer, only a very selective group of population, they are being considered for surgical resection. So this red is actually surgical resection group. All blue boxes are for non-surgical management. And you can see that it's actually filled up with the blue boxes. So I do agree that for a very small group of patients where we have seen or we see tumor nodules in different lobe, where surgery may hold a significant role in the management, but yet radiation chemotherapy remains a component of the treatment. Now, why the role of surgery is so controversial? 4 different randomized studies from 4 different countries, including UK, United States, France, and Japan, they have all failed to accrue the desired number of patients when they try to conduct randomized studies on the role of surgery in resectable stage 3 lung cancer. And essentially, all these studies actually recruited very few number of patients. So we are talking on a treatment modality which actually failed to accrue a desired number of patients across different countries in randomized studies. Let us look at the cumulative data of available randomized studies, which actually compared the role of surgery and radiation. And these are 7 studies, and you can see that all these studies where surgery and radiation were actually compared as treatment groups. There is no significant difference in outcome when you talk about the benefit of surgery, when you talk about the role of surgery or radiation in resectable stage 3 lung cancer. And see the number of patients, it's not very less, 1,322 patients from 6 studies. And it also says that survival was not significantly different concurrent when we compare with concurrent chemoradiotherapy. Within 2 years, concurrent chemoradiotherapy actually showed better survival and less mortality. So in first 6 months, there are more mortality in the surgical arm compared to non-surgical arm. So a treatment which does not give any additional benefit but gives higher mortality and morbidity, I do not think should be a standard of care in today's time. This Spanish group essentially came up with some treatment paradigm, and again you can see that for stage 3A N2 disease, it's all about radiation or combination of radiation and chemotherapy, and essentially surgery holds a very insignificant role in the treatment paradigm. Of course, after a publication of Pacific trial, there is significant role of Durvalumab, and we will also see that. So this says that surgical resection after induction therapy is indicated when imaging tests rule out extrathoracic disease progression. Functional assessment after induction therapy indicates that the patient can tolerate the resection, and restaging techniques confirm an improvement of the mediastinal status, and the type of resection ensures a complete resection but avoids a pneumonectomy. So a complete R0 resection for the T and N are both important to achieve R0 resection and a successful surgical outcome, which is not essentially easy. So this URTC randomized study is one of the most landmark studies which actually compared head-on after induction chemotherapy for resectable stage 3A N2 disease. And it showed that surgical resection did not improve overall or progression-free survival when it was compared with radiotherapy. And it also said that in view of its low morbidity and mortality, radiotherapy should be considered the preferred loco-regional treatment. And we should not forget that it's almost more than a decade. And by this time, the radiation technology has evolved, and now it is even better to reduce the so-called apprehensions of radiation-induced toxicities. A detailed analysis of the URTC study also showed that the mortality rate was significantly higher, and it was almost 4% in the surgical arm within post of 30 days. The other complications which were significant, it included pneumonia, respiratory insufficiency, arrhythmias, air leakage, cardiac decompression, empyema, and bronchopleural fistula. 8.1% patients underwent reoperation due to positive margins, pneumothorax, empyema, and bronchopleural fistula. Now, we can say that in absence of definitive evidence of any benefit of surgery, chemoradiation or induction chemotherapy followed by chemoradiation should be the standard of care. But there is more to this. Now, after publication of this specific study, we can see that although it was actually planned for unresectable tumors, more than 50% of the patient in both the groups, both in the Durvalumab arm and in the placebo group, they were actually stage 3A. And it also showed that Durvalumab has better outcome even in stage 3A patients. It had better response, 28.4% versus 16% compared to placebo. In the initial publication of 2017, it showed that Durvalumab has better probability of progression-free survival. At that time, it did not reach the median survival. And that holds true even after the after the 4-year median survival publication, which holds the initial results true for now as well. You can see that at 1 year, at 2 year, at 3 year, and at 4 year, every time Durvalumab arm had better outcome compared to the placebo arm. It also holds true for the progression-free survival. And a post-hoc analysis showed that the number of events are actually less in Durvalumab arm in stage 3A compared to placebo arm. The toxicities with Durvalumab in this study was well tolerated and they were not significant. Grade 3 and grade 4, if you see, they're quite acceptable and negligible. So when it was seen that Durvalumab holds a good role in stage 3A tumor, a detailed analysis was done and it was published just a few months back. And it says that consistent with the intent to treat population, treatment benefits with Durvalumab were confirmed in patients with stage 3A N2 unresectable non-small cell lung cancer. So prospective studies are definitely needed because it was not a properly designed study, but definitely Durvalumab shows response in resectable group also. Now, when we compare about the probable side effects of radiation or chemoradiation versus surgery, you can see that there is a significant difference in nature of side effects. So the majority of the side effects associated with chemoradiation are fatigue, nausea, vomiting, esophagitis, pneumonitis, carditis, pericarditis, risk of rib fracture and brachial plexopathy. But practically what we see are fatigue, nausea, vomiting, esophagitis, and pneumonitis. So rib fracture, pericarditis, brachial plexopathy with today's ion radiation technologies, if done properly, are really very less. Compared to that, if you see the risk associated with surgery, there are always risks associated with anesthesia, bleeding, infection, leakage, pneumothorax, thromboembolic events, and volume loss after pneumonectomy. So now the ASCO guideline, which has recently been published, particularly for the stage 3 tumors, it also has given certain recommendation. And if you can see that the role of surgery is applicable only if all the following conditions are met. So only if all the following conditions are met. A complete resection of the primary tumor and involved lymph nodes is deemed possible. So if any one of these two are not possible, then one should not go for surgery. M3 lymph nodes are excluded. Perioperative or 90-day mortality is expected to be very low, which should be less than 5%. And it also says that patients with stage 3 non-small cell lung cancer generally should not be excluded from consideration for surgery by non-surgical physicians, which we radiation oncologists usually believe, and definitely we involve our thoracic surgeon colleagues in decision making. It also recommends that patients with stage 3 non-small cell lung cancer receiving concurrent chemoradiation without disease progression during the initial therapy should be offered consolidation Durvalumab for up to 12 months from the Pacific study. So at the end, if we weigh between the risk and benefits, we can see that instead of surgical treatment, a non-surgical approach gives equally good result, if not better, which is essentially non-invasive, less morbid, involving minimum hospitalization, and definitely it involves less mortality risk. So to conclude, I think that stage 3A and 2, it's a heterogeneous group where the role of surgery is very limited and which is applicable for a very few patients. Randomized trials are not available to show any benefit or any additional benefit of surgery over non-surgical treatment modalities. Even in the studies where the surgical treatment was compared with non-surgical treatments, the data was not in favor or showing any additional benefit with the surgical arm. Durvalumab is effective in unresectable stage 3 cancer, but it also shows its benefit in stage 3A N2 and non-N2 groups. Chemoradiation followed by Durvalumab should now replace surgical treatment for such patients. I appreciate your patience, and over to you, Dr. Animas.
Thank you, Dodullah. Thank you for your nice presentation. I'll move on to the next debater, which is Dr. Tanjeel Janjua. So Tanjeel has been my colleague back in my training days in the UK. Very helpful guy. Even during my consultant episode, he was with me. So now he's a consultant clinical oncologist currently working in St. James's University Hospital, Leeds, UK. He is specialized in treating lung cancer and urological cancer. Dr. Janjua has keen interest in image-guided radiotherapy, stereotactic radiotherapy, and systemic therapy for lung cancer. Over to Dr. Janjua, and he will be speaking against the motion.
Thank you very much, Animesh. Just gonna share my slides. Just let me know when you can see them. Okay. Thank you, animation team, for giving me this opportunity to speak at this meeting, and congratulations on arranging such a fantastic meeting. I think the agenda was superb, and so far it's been great to hear all the speakers. So I'll be talking today regarding the non-surgical treatment with chemo-rad followed by Adjuvant should replace the surgical treatment for resectable stage 3 non-small cell lung cancer, and I'll be talking against the motion. So I'm a clinical oncologist, so always would love to favor radiotherapy and chemotherapy combination treatment. So I think we have to be very careful when we are interpreting any data. We as a scientist, and especially in this era when we are practicing evidence-based medicine, I think it's really important to kind of look at evidence and interpret in a way where we are implementing in its true spirit.
So can I request you to make your slides full screen?
Oh, sorry, it is full screen on my one.
So not at our end, sir. And are you on the first slide, sir?
Sorry about that. So essentially, a fantastic talk from Dr. Mondal, and I think most of the evidence that he's touched upon is actually what I'll be talking about as well. So a few important facts. We know that this is a very complex heterogeneous group, so it's difficult when we are discussing these patients in MBT to define what's the right treatment option for them, and the main discussions are about what is resectable and what is not resectable. Another important aspect is to look at these patients upfront is that they carry a high risk of local as well as distant mets. So your strategy should cover both these aspects at the beginning. We know that stage 3 lung cancer is a multimodality treatment with an individualized approach. We have all talked about this before. There's a clear need to improve the outcomes. We know about 1/3 of our patients with stage 3 disease is 5 years or alive. And just looking at these graphs, I wouldn't go into detail. This has been touched in previous presentations as well, but certainly there's a lot of room to improve there. Just to give you some visual presentation of what stage 3 means and how heterogeneous it could be. So just look at these slides and see what you would be thinking about regarding these options of surgery and radiotherapy. So you might have a relatively small sized tumor, but with a single station and node. You may have multi-station lymph nodes in the same situation, or you might end up with a relatively bigger tumor with more nodal volume. You might have an N3 disease, and you might have all these features of high-risk disease with multiple nodal station and a very large primary tumor. So just gives you an idea when we talk about heterogeneity, when we talked about an individualized approach, just even looking at how the distribution of the disease could be, it's amazing how much difference that it is in presentation of disease at different stages. And the most important thing here, we've talked about the evidence base. Evidence base is all in resectable disease. So it's very critical to see what was defining this resectable disease. And unfortunately, in this era where we really moved on with very great imaging and pathological staging, we sometimes still struggle to define what is resectable. So this was the paper with Everson and colleagues, which was published in 2019. And essentially the two important points they were highlighted in in a potentially resectable N2 disease was that they wanted a pathological confirmation of the nodal disease at least 3 nodal stations. We know mediastinoscopy and EBUS are widely used now, and patients were encouraged to have a PET scan as a minimum, MR brain as a starting point. So we get a really good idea of where we're starting from. The primary tumor should have a high probability of clear pathological margins and complete resections, preferably avoiding pneumonectomy. I'll discuss the evidence around that. Again, it's very important for you to try your best to assess with your surgical colleagues and radiology colleagues that this is likely to be a good resection in the end. And easily measurable and defined metastatic N2 disease, lymph nodes should be free from major mediastinal structures, including great vessels and trachea, and size should not be greater than 3 centimeters. Again, trying to define that we have a consistency on how we are looking at these patients upfront. Now, again, my colleague went through this as well. So what we have kind of really got a good consensus in unresectable disease with chemoradiotherapy. We know the chemoradiotherapy is better than sequential approach. We now know that immunotherapy has got fantastic result with the specific data, though we have to look at this data carefully, and I'll come to that in the end. But it's mainly the resectable disease where we have no consensus. And I think it's a good thing in a way, because we are looking at each individual patient in a different way and trying to work out what's the best approach in them. And let's look at some evidence around that. So what are the approaches? Number of different approaches. A lot of neoadjuvant and adjuvant data was discussed by my colleague earlier. So a lot of exciting stuff coming. We know that these patients are offered concurrent chemoradiotherapy upfront in surgery. Some patients will be offered treatments in adjuvant setting, which chemotherapy we commonly use with or without radiotherapy. Then we have used neoadjuvant chemo alone, followed by surgery with or without radiotherapy, and we've discussed the specific data, but also we have used chemoradiotherapy in resectable disease as well. So just need to look at what's the role of IO and targeted therapies, given that we are in the time where everything is evolving so quickly. So just move on to the next slide, please. So looking at the major guidelines that we follow, NICE came up with in 2019 with this guidance that we should consider chemoradiotherapy upfront in neoadjuvant setting in N2 disease, which is really interesting. And I'll talk about the evidence in that. I must say this is not something we practice in the UK. There is trend towards it, but this is not something we are all practicing in this setting. So there is a lot of variation. ASMO says there's no recommendation can yet be made, and MDT to decide on multimodality strategy. And the NCCN more or less takes the same approach, but again, just highlighting the fact that radiotherapy and induction regime hasn't really shown a lot of survival benefit and long-term outcomes. So the NICE did a meta-analysis looking at 10 randomized control studies, which looked at a multimodality treatment, neoadjuvant setting, mainly chemoradiotherapy versus surgery, or chemo alone in neoadjuvant setting versus surgery alone. So they had these 3 arms, and the outcome they came up with, that's mainly they said it's quite cost-effective thing if we can give chemoradiotherapy upfront with a good outcome. They did see some better progression-free survival, and there was some trend towards better overall survivals, but nothing really significant. But the downside of all this trial was that there's a large heterogeneity in the trials. None of the trials individually showed there was survival benefit. So you can argue why you're seeing the trend. And this didn't include any immunotherapy studies. So looking at neoadjuvant chemoradiotherapy and surgery in this setting, very difficult to recruit. We've talked about that in SABRE setting as well. But anywhere we are trying to compare these modalities. These are not easy studies to conduct. The 2 modern day studies that I want to talk about is the Albion study, which was published in 2019. Again, they looked at specific N2 group. They had induction chemoradiotherapy with cisplatin-based chemotherapy and had up to 45 gray, followed by randomization to surgery at 4 to 6 weeks, or they went on to have up to 61 gray chemo-rad. So if you look at the outcomes, unfortunately, there was no real survival benefits seen. The results didn't prove one treatment to be better than another. It was quite decent sample size of 396 patients. There was some improvement seen in progression-free survival in the surgical arm, But unfortunately, there was quite high morbidity with actually mortality of around 8% in patients who had pneumonectomy. So that kind of pushed people to try to avoid pneumonectomy and go for lobectomy as a plan upfront. The Absute study was another phase 2 study. It's a quite interesting study design. If you move to the next slide, please, it might be easier to look at the pictorial form. So sorry about this busy slide, but essentially patients were offered induction chemo upfront, followed by chemo-radiotherapy, and then they were randomized to chemo-radiotherapy or surgical arm. So quite an intense treatment regime. Again, it didn't show any difference in both the modalities in overall survival or progression-free survival. Very good median follow-up of 78 months. But what this trial did show that overall the 5-year survival was very impressive of 34%. So they actually showed that both these modalities were quite good in controlling the disease. Just looking at these Kaplan-Meier curves, so again, not much difference, but good outcomes eventually in both arms. Then we've got this another SAC16/00 study, which looked at neoadjuvant chemo RT versus neoadjuvant chemo alone. Patients again had resectable disease. They either had 3 cycles of chemotherapy in neoadjuvant setting, or they had 3 cycles of chemotherapy followed by sequential radiotherapy. Now, if you look at the R0 resection, it was actually better in sequential radiotherapy. But again, there was no real difference in the survival outcomes. What the trial concluded was the RT was active in neoadjuvant setting. There was response, better complete resection PCR rates. However, it's not really translating into long-term disease control or survival outcomes. What this study did show that actually pneumonectomy was actually a safe procedure to do, which was interesting given what we previously saw. Now, just looking at the meta-analysis, I think my colleague already touched on that systemic review and meta-analysis of 6 trials, which looked at neoadjuvant chemo alone in 4 trials and induction chemo-rad in 2 of these studies. And again, it didn't show any difference in both the approaches. So again, just touching on the evidence around what we've got in adjuvant setting, because it's important when we are offering patients any modality, either surgery or radiotherapy upfront, we know what are the likely options after that intervention. And we know from the lung ART study that patients who had N2 disease, bear in mind this was a group of patients with R0 resections, they didn't had any significant disease-free survival outcomes at 3 years. But what it did show was that these patients who were offered radiotherapy did have increased cardiopulmonary toxicity, which can be life-threatening. So the grade 3 toxicity was significantly more than in people who had post-operative radiotherapy. So it's another important consideration in planning the treatments. Our colleague has already gone into details of adjuvant and neoadjuvant data that and treatment options we have got available. We all know the LACE study with 5-year overall survival. Again, we know the main benefit comes from high-risk groups. So again, one important option there. Adjuvant Aussie data has been discussed. So I know this is, we are waiting for survival outcomes in the long term, but very promising data with a hazard ratio of 0.17. Again, had 3A disease patients in there. Adjuvant immunotherapy after surgery, again, very exciting times for us. There's 6 phase 3 clinical trials being evaluated looking at monoimmunotherapy. So just to show you that, look at these phase 3 trials on the left. And if you look at the study end, trials are hopefully be completing their, this will be completed in the next few years. So we will have a very robust data of immunotherapy outcomes in hopefully next few years. We've already talked about Empower 010 study earlier in the UK. We have now got CDF approval for atezolizumab in patients with more than 50% PD-L1 expression in stage 2 and 3A. So again, another very good option. The neoadjuvant strategies with immunotherapy, Checkmate 159 study. It's a phase 1 study with a promising results. A NEDIM study has been talked about earlier, very impressive data. Actually, next one, please. The NEDIM studies looked at Nivo with combination platinum-based chemotherapy with excellent results. major pathological response of 83%. So again, this is a very important study looking at combination chemo-IO. So the other interesting thing was there was no increase in immune-mediated toxicity in this combined setting, which is, I think, is very, very reassuring. And the major side effects in grade 3 and 4 setting was hematological. Obviously, this needs a phase 3 confirmation study before we can implement into clinical practice. Again, in this setting, we've got phase 1 and 2 studies in neoadjuvant setting. You can actually move forward. I think I can skip these slides. We are now looking at neoadjuvant radiotherapy and IO combinations. Just wanted to show you this. This is interesting because with radiotherapy and immunotherapy combination, we are always a bit apprehensive in terms of toxicity. And these are all phase 1, phase 2 studies, but they are looking at combining these two modalities in concurrent setting. And so far, we haven't really heard from any of these trials. It's too early to say maybe, but there's no real concern that has come out when they've combined these modalities, which I think is really encouraging. Just a couple of quick words with Pacific study. I think we're all very excited, and clearly it's a very impressive data. But just to point these things that this data has got very fit patient cohort, which I'm not really sure are true lung real world patients are. The data doesn't really tell you what we did with chemoradiotherapy setting. What were the radiotherapy volumes? What were the techniques? What were the OAR doses? This trial was randomized post-chemo-rad. You don't really know how many patients actually ended up going into randomization. We know that following chemo-rad, they can only go in on IO if they were still PS1 and they didn't have a grade 2 toxicity. So I think there are a lot of important things to actually consider rather than just following it blindly. It's still very impressive data, but just a bit of caution there. And we're still learning about the optimal duration of IO and timing of IORT. So I'll just conclude to say that this is a very heterogeneous group. We have got different potential approaches with good outcomes. So surgery is indicated in some and not, but certainly it's a multimodality approach, and patients shouldn't be denied surgery based on the evidence that we have got if they are deemed eligible and if they want it. We'll soon see IO coming around perioperative setting, probably will influence the results in decision-making, and non-surgical treatment remains an option, but no evidence to support that she should replace surgery in resectable patients in stage 3. We shouldn't follow a blanket approach based on a trial which was not done in the setting which we were talking about. Thank you. Apologies for the issues with the IT.
Thank you, Tanjeel. Thank you for your nice presentation. Can we have a quick rebuttal from Dr. Dodul Mondal? If you've got just some quick comments.
Excellent presentation, Dr. Janjua, and I think yes, we should not fight. Although it's a debate, I understand, but yes, we have to accept that there are a lot of flaws in this stage 3 resectable lung cancer. The very definition of resectable lung cancer, stage 3 lung cancer, is very much questionable. So till the time there is a proper definition of what is resectable, yes, we have to ultimately depend on the MDT decision. And my contention is to make one thing very clear, that it's very sad to see that many times, even in MDT discussion, the role of chemoradiation is being ignored, and that should not. That perhaps we definitely should discuss about the significant role of chemoradiation in this setting, rather than blindly going for surgery also.
Thank you. Any final comments? Any rebuttal from Dr. Tanjeel?
Absolutely agree what my colleague has said. I think there is no one blanket approach. Chemoradiotherapy is a very effective treatment modality. This is a complex group of patients. So I totally agree with him. We should assess patient on an individual basis and consider all treatment options, keeping in mind the neoadjuvant and adjuvant options coming through. I totally agree with him.
I think we have to conclude this session here. Thank you both.